Hey, thanks for the introduction, and I'd like to welcome everybody to the webcast and thank everybody for taking time out of their busy schedule to listen in, because this is certainly a topic that's getting a lot of interest right now, getting a lot of traction. There's big stuff happening in the space. Obviously, big data, quote unquote, things that data at that scale, at very large scale, is becoming a topic that's of interest at pretty much every level on every continent, and so we're just happy to be here today to talk about it. And what I'd like to start out by talking about is just kind of what the problem of too much data in healthcare means, and we'll do that, and we'll paint a picture of the direction clinical medicine is going to go in the age of big data, or at least what we're seeing from the point of view of the research enterprise, because healthcare is a complex space, obviously. This talk is kind of a vision of some of the future elements with a focus on technology and data science aspects. So the goal here is not to get too far into futurist mode, which, like people walking on the moon kind of, well, I guess that already happened, but it's not a good example. People living on Mars, far out kind of stuff that is more the domain of futurism. But I want to keep it more or less grounded in what we think the near future is, and things that maybe have not disseminated far beyond the context that we're operating here in the research enterprise, and we'll see. We'll take a look at all those things and see where it's going. All right, so the challenge here is first to take a look at this picture, and it pretty much obviously is a crowd picture. So this is a picture of a huge crowd, and with a little touch up you can pixelate it, and which I thought was kind of neat looking, because it sort of retains some of the individual nature of the people in the picture, and also starts looking quote unquote digital. And if you look at this picture and you think about how many people are in this picture, just think about this at a global scale. We're going to have data for all these people, and all these people will touch healthcare at some point in the future, especially with new systems coming online and things of that nature. So there's plenty of healthcare data being generated, or soon will be generated and harnessed in some way. Examples are data off of hospital monitors, for example, readings, things of that nature, images, image data, which is what EKG basically turns out to look like. This is more or less just expanded EHR data, or health record data, but it's a lot bigger. Things that are coming off of EKGs are, like I said, image data, so they're big. They scale like image data, and they're basically more or less opaque. And then we get into things like genomics data. This is even bigger data. Reads off of sequencers are pretty huge. So let's say we can get all this data collected in some way and stored, which is hard enough. Having a bunch of data is just not really sufficient. So we need to figure out how to do something with it. The short answer to the question of what to do with it is what I'll call data science. That's kind of the short answer. And the longer answer is this talk, or at least part of the longer answer is this talk. But seriously, we need a sophisticated infrastructure that can weave together things like clinical genomics, security, decision support, and do all this in a way that supports the point of care and doesn't just sit in a research system or some hospital data warehouse somewhere. So an infrastructure like this would need to provide a way to manage and share data, big data. It needs on-demand analysis support, and it needs security, needs ease of use at the point of care, and all that stuff. So it's kind of asking for a lot. Now, some of the drivers here, just to back up a bit and give some context about healthcare drivers in this new age. we're seeing increased demand, and this is going to be a bit U.S.-centric, but obviously we have healthcare legislation coming into effect. We have demographic changes here with an aging population. Population's growing, so more people are entering the system. There's a provider shortage here, which makes things tougher. So all these are sort of challenges that come into play in terms of demand. Also in the U.S. especially, and well, this example is the U.S., but I'm sure similar things exist in Europe. There's regulatory frameworks that have to be complied with. So here in the U.S. it's HIPAA and high-tech, where you have business associates and covered entities who have significant downside if they disclose information in an inappropriate manner. In fact, HHS's fees are on the order of $50,000 per violation if you're found to be in willful neglect, and then there's always a possibility of lawsuits at the state level in various jurisdictions, and there's public relations risk, et cetera. So security is coming into play with the new regulatory frameworks. The Web 2.0 model is also starting to kick in a sense, in that you see an increase in social approaches to healthcare, such as Patients Like Me, which is more or less a crowdsourcing effort for comparing treatment and outcomes among a group of different patients. Medical research itself, of course, keeps generating new advances. There's a lot of push from the large funding agencies, such as National Institutes of Health and others, around collaboration across researchers and labs, and encouraging multidisciplinary efforts, and also translational efforts to realize concrete benefits of different sorts out of research dollars in the space, and we'll talk a little more about that later. The last thing I thought worth mentioning here was moonshot, what I'm calling moonshot initiatives. These are things that are just basically disruptive at the science or delivery level in terms of healthcare. So there are institutes like the Faster Cures Institute, which is a center of the Milken Institute, and they're focused on basically doing whatever it takes to get cures faster. That's their raison d'etre, and that's what they focus on. And then on the science side, you have SENS and Aubrey de Grey's work, which is starting to receive some mainstream coverage. It's basically centered around eliminating or curtailing human aging, but for the obvious reason, because death's not a fun thing, right? And aging is not a good thing either. But also, aging is the basis of most major diseases that we're dealing with. So if you think of the major healthcare dollars and problems in the healthcare system caused by disease and so forth, people coming in, young people are not the ones getting these diseases. So the idea is to try to attack aging at the foundations of aging with different approaches. Google's just stepped into the fray with a project called Project Calico, which is, at least it is thought, is going to be focused on dramatically extending human life, according to what was reported by Time magazine. So those are all things that are happening in the broader context that are giving us, they're moving the space forward. Now, in the more narrow context of the meat of this talk, I've got a list of change drivers in the research enterprise. So what do I mean by the research enterprise? That's the first thing to tackle. Loosely, the research enterprise is a collection of public and academic research efforts. It's sort of an archipelago of research universities, federal labs, public-private partnerships, and things like that. And there's private commercial research, obviously, that is very good. It's a little bit harder to get visibility into that because it's obviously closed for the most part. But the National Research Enterprise is doing a lot of work involving healthcare and all kinds of things that feed into big data, computer science, information science, The list goes on, and usually this is just organized under the auspices of whichever academic department is relevant. So you have computer science work going on in computer science, no big surprise. Med schools are doing the medical research. Library science schools are doing library science research, and that sort of thing. So if you take all that as a chunk and say that's the research enterprise, then the place where my primary appointment is, which is called Renci, is a research institute within that context, which essentially means that we have a mission, and I call our mission "Powering the Research Enterprise." That's my own slogan. But the basic idea is we're very technology and domain focused, and we exist outside of an academic context. So we are a little bit in between multiple worlds here, and we're able to bring in technology, advanced technology, and use that to power up research. And that's what we do. And at the same time, we're supporting a few different selected free open source software initiatives and products, if you will, that we found have common value across different disciplines and help us solve technology problems. Just a tiny bit more about us. We have some compute clusters. We've got about 30 teraflops sitting in different places. We've got about 3 petabytes of spinning disk and some other types of storage, and tape storage, and a flash storage system, which is pretty nifty. And we're sitting in the middle of a lot of these research projects, which gives us a place where we can make observations across these different projects and domains and so forth. So if we're thinking about the research enterprise, then the drivers that are coming through on healthcare at this point, I've got a list of them. I'll go into depth on these because these are pretty interesting. Personalized medicine, translational medicine, evidence-based medicine, or EBM, data science, and various data technology factors. So let's start at the top of the list, personalized medicine. This is a project, personalized medicine broadly means customized healthcare. Okay, that's not really complicated. Narrowly, however, it's really come to mean, I think, using genetic differences to tailor interventions and treatments. And a lot of the goal, from my perception of it at least, has been to just reduce problems with adverse reactions against drugs. So you can look at genetic profiles and see what you think of an individual patient, and see what you think the outcome of administering a certain med to that patient would be. We have some projects at UNC around this, the University of North Carolina, Chapel Hill, which I should also mention. Renci is chartered out of UNC, also Duke University and North Carolina State University. We have a project that we are collaborating on as a technology piece called NC Genes, which is a big project here out of the med school. And it's a system that's looking for variants that are linked to diseases in individual patients. So essentially, you take a Wes of the patient and then produce, you sort of diff that again, or look at the difference of that between that and a reference genetic profile, and use that to create an individual treatment plan. Our role in that one has been to do a lot of the pipeline, of the sequencing pipeline, the analysis piece of it for variants. And that's got Hadoop in there, workflow technologies, some data middleware technologies, and we're now working on cloudifying it, for lack of a better word, or essentially making it scale out in the manner you would see, in an elastic manner you would see with cloud services. On the translational medicine and the EBM front, we have several projects, and the first one is Secure Medical Research Workspace, which is an on-demand way to create virtual workspaces that are useful for keeping data that's not supposed to get out contained. And the point here is to get research data into the hands of researchers and avoid some of the problems that are keeping research data essentially in the data warehouse. And that's the whole disclosure and liability type issues that we mentioned before with HIPAA and high tech and so forth. The point of this is, as a translational medicine effort, is to enable research, to get research and that data into the hands of researchers so they can get their research accelerated, so that we get from, as the slogan has been, bench to bedside faster. So you want to get the results out of the lab bench, and get them to the bedside of the patient. And that's the whole deal with translational medicine. That's the point of it. NIH, the National Institutes of Health here in the U.S., are very keen on this, and we're seeing a lot of push in different areas to bring translational medicine into being. And in fact, we have a whole center here at UNC that's geared toward translational medicine. So we take it quite seriously. Evidence-based medicine, I should mention also, using study data, statistics, meta-analysis, and basically statistical and mathematical tools to come up with evidence that is then applied to clinical judgments, or used by a practitioner to customize treatment or to make a determination about what to do, instead of the model of just more or less relying on the judgment of the practitioner. This is an attempt to codify that and put study data behind it and put statistical techniques behind it. So the VDL tool, Visual Decision Link, is another collaboration we have that uses visual analytics to help the clinician evaluate and understand the effectiveness and risk of different therapeutic options. This is all based on study data and cohort data. Essentially, taking comparative effective research techniques, which is looking at subpopulations who have share certain characteristics, and looking at the outcomes that they've experienced on various meds or treatment regimens or what have you, taking that, using that as the evidence-based medicine base, and then applying visual decision support over top of that. That's the nature of this project. And also should mention in here Real Tromans, which is it's an analytic system that sits in line with data coming off hospital monitors in a pediatric ICU, and it uses digital signal processing techniques, transforms, and lots of magic under the covers to actually try to predict adverse events for pediatric patients. So again, another example of trying to bring some of these things out and to the bedside of the patient, some of these advances that exist in statistics, math, DSP, all of these different ongoing research areas. Data science itself, which is probably a familiar term to many on the webcast today. Everybody's got a definition. We have a working definition too, and this is in association with the National Center, the National Consortium for Data Science, which is also an initiative we're involved in. I'll just read this. Data science is a systemic study of the organization and use of data in order to accelerate research discoveries, improve critical decision-making processes, and enable a data-driven economy. All right, fair enough. Some examples are classifying breast cancer into 4 primary forms. This was derived using genetic profiling data. Data derived from sensors is being used for car safety features. Data processing techniques developed at Stanford obviously famously fueled Google. So those are different examples of data science, maybe not in name at that particular time, but at least in effect. And on the academic curriculum side of this, also there are a number of curriculum additions going on at UNC and other places, including at the UNC School of Information and Library Science, which is my affiliation. There's overlap with the data science curriculum has overlap with information science, informatics, statistics, computer science, math, and other disciplines. So it's kind of a new thing, and the academic side is definitely responding and trying to get a stake in the ground about certain aspects of theory and the foundational elements of these things. Now, the project that's listed on the slide with the logo up there is DataBridge, and that's an applied research project we're doing at Renci in this space. The idea is to bridge data sets. Hence, it's not just a clever name, I guess. The point is to investigate similarity metrics between different data sets, and the use case is long-tail science data that's sitting in all these labs that are funded by the NSF, or National Science Foundation here in the U.S. So essentially every lab's got data sitting out there, and what do you do when you want to use somebody else's data, or you want to find somebody else's data, even figure out if it's relevant to what you're doing? Well, it's kind of hard. So the point of this project is to develop similarity metrics and develop a kind of a test prototype framework to put them to use, just to see if we can do this in a meaningful way and link data sets together for use in different practitioners. So obviously this same concept, if it works, will be applicable to medical data too. There's no reason why it wouldn't be. All right, so flip the slide. The last thing on my list of change drivers that we're seeing is just what I'm calling technology factors. So storage and data management, which the capability of storage systems is famously very rapidly increasing. It's pretty interesting, actually. If you look at the chart, you can see that this is a great graphic showing Kreider's law versus Moore's law. On the storage side, the Kreider's law is the conjecture that storage density of disk drives doubles annually, and Moore's law is the conjecture that the density of transistors, or the number of transistors on the chip, doubles every 2 years. Now, there's also the 18 months variant of that too. Without getting into that, I think the original or modified original version of Moore's law is 2 years. So in any event, you can look at the chart and see the growth there and the comparison. So what does this mean? Well, first of all, this is the reason why we're having this little chat here, because if storage didn't, if the cheapness of storage or the cost of storage had not gone down at the rate that it has, we'd still be trying to fit things on the floppy disk and stuff. I mean, so there'd be no big data revolution. There'd be no large scale anything, or large scale would be very small scale. So that's the big thing that driving everything in the data space. So on the integration side, how fast does our capability to integrate data increase? It's a hard one. There are tools for this. There's tool support, there's commercial tools and free tools. A lot of these are just one-offs. It's a hard problem when you start trying to make data models become equivalent or come up with some crosswalk between data models. It's not easy. But tool support is increasing, and body of knowledge is increasing around how to do these things. And standards help, and semantic or linked data, semantic web technologies also help too. So we're making some progress in that arena. Analytics, the technology underneath analytics keeps improving. We have excellent commercial tools depending on what you want. This SAS data, R is a free tool. Parallelization at all levels is increasing. There's a lot of active work being done in computer science on parallelization algorithms and how to do parallel programming and how to parallelize everything that can be parallelized to make it scale. And it's pretty hard. If you've ever done any time in the trenches with trying to write parallel code, even in environments that support it, it's very hard to reason about it. It's very hard to debug it, things of that nature. So it's progress is being made. It takes time. And finally, the body of knowledge, which is a collection of just best practices and formal education and data within knowledge within different disciplines, sub-disciplines, that's all increasing too. So these drivers are all going to push us into this future where we can deliver some of the results that we want to see in healthcare. Still in the technology world, let's look at the 5 V's. The V's of big data, I believe Gartner came up with the first 3 as aspects of big data, the big data problem to consider: volume, velocity, and variety. If you apply these to healthcare, you can think of volume. This has already been mentioned, but the number of patients in a system going up, the size of patient data with genomics data, and especially if you get into trying to save every piece of data about every client of the healthcare system, that becomes huge. Velocity, the number of visits, the amount of what I'm calling remote data, meaning check-ins via e-medicine type systems and telemedicine, things like that. Variety, what's the variance across the data in terms of the different types of data? And there's a lot of variance here. There's everything from structured data to extremely structured data that's within hospital systems, within relational databases. There's text, just text of physicians' notes, which is kind of a hard problem to assimilate into any system that's using any machine learning driven system. You have to assimilate that knowledge into the system, and it's just free text. It's hard to do that. A lot of it's still written and has to be scanned in some way and then go into the database, which causes the data to be dirty, and it causes lots of other things. So then lab data from all kinds of instruments, all different companies, all different formats, procedure data, genomic data, which is coming in now, and again, those are different formats also. They're semi-structured, or they look like huge blobs of binary data that do have some structure, but they're not relational data. So they're not something that the whole database industry has been geared toward relational data, and they're not something that's easily digestible. So if you look at those and then add also the other 2 of the 5 V's, the veracity, data quality, and value, well, so these are a little more up in the air, but they're still worth looking at because you've got a huge data quality issue, and that's always where these efforts fall down. If you're doing them in practice, you can do whatever you want on a whiteboard, but there's the whiteboard keyboard gap, which is what I call it in programming, but this is a whiteboard database gap, because you draw this thing we're going to integrate all these systems, and data comes here, and it's this and it's that, but then you realize that people don't even take temperature the same in different clinical settings. is it taken, when is the temperature or blood pressure of a person taken? They're not the same, even though they're called the same thing. So it becomes really a tar pit to navigate those. And if you take those problems you have at a normal scale and then multiply them out to the size we're talking about, they become, it becomes a serious issue. All right, so this is my favorite slide in the deck. In every slide deck, you've got your favorite slide. This is even funnier because the guy I'm quoting here, Eric Scott, didn't actually tell him I was going to do this, but I did show him in the end. So I gave him a veto on it. So I just made this up, this Scott's data raiser, because this was actually from an email to a list internally, where he asserted that it's a discussion about practicality, practical terms of what these things mean, and he says big data is the point where file systems get unwieldy and RDBMSs start making ugly compromises, and generally big data is going to come off of high bandwidth sensors, where you define sensor loosely. It's not really typically thought of as people typing, although if you have Facebook and places like that, or they have a million people typing in parallel, so you do get that scale. But usually you're talking about, like in the sciences, you see things like at the collider systems. The physics domain has a huge amount of data. They don't even save it all. They've got tremendous data. And that's the kind of thing where, like LHC and those types of labs are generating. That's real big data. So if you're looking at, for example, the EKGs in a hospital, they produce about 21 megs per day, let's say. If there's 125 of them, or 150 or whatever, you're talking 3 gigs a day of data. So that's getting up there. In terms of genomics data, we have a couple of federated data grids here that are using a system called IRODS, which I'll mention later. They have about 750 terabytes in them right now, and that's not the full load. It will go up substantially. That's just what we're using in development right now. So that's kind of another take on the big data question and what that means. So if we have to put a stake in the ground and say, what's a vision for the future of healthcare we'd like to see? What are the attributes of this? Well, we'd like it to be, as alluded to earlier, personalized, with this to be based on people's medical records and genomics, and tailored to the person. Data-driven, because we have all this data, and in some sense we know how to use it. It's just we don't totally know how to use it. But the bigger problem is deploying it and making these things into production quality systems, which is, obviously a lot of ongoing work in different places. We want this stuff to be portable, which is like the Veterans Administration here in the U.S. has a system called Blue Button that originally was for letting patients download their electronic health records, and they've since expanded it. But we want the system portable so that healthcare data can move from one provider to the next. You don't have to go into an office and sit there and fill a form out that is the same exact thing you've done everywhere else, and you have to waste that time. And plus, the providers don't see each other's the work of any other provider. They operate more or less in isolation. Mobility's got to be taken into account. Mobile devices, that is, what that means is kind of obvious. Integration with clinical systems of various sorts. Again, not an easy problem, but we need to solve it. And point-of-care decision support, a big one. This is, as we alluded to in the VDL project earlier, we want to give tools to the practitioner to aid them in making a diagnosis and treatment, and setting up treatment alternatives. So there are, in fact, initiatives in various places focused on innovating in these areas. Mayo Clinic here in the U.S. has a Center for Innovations that is probably worth you checking out on the web. It's focused more on the delivery of healthcare. So they're doing different things that are point of care, so not necessarily technology oriented, but a few of them are. So it's definitely worth checking out. So to get there to this dream world of perfect healthcare, the infrastructure's got to have certain capabilities. First of all, the data management side of the infrastructure has to scale properly, which is, of course, another thing that's easy to write on a whiteboard and hard to get to work in practice. Cybersecurity, privacy issues have to be addressed. Usually security is a bolt-on at the end of a product and is typically not designed into products. And then when bad things start happening, then there's a remediation effort. This may be the model that's we're always doomed to follow, but not necessarily, especially here in terms of gearing up for HIPAA and high tech here in the U.S., where you're well advised to handle this at the CFO or legal level of your organization if you're dealing with any type of healthcare data. Cloud elasticity. Ideally, the back end of this type of system would be elastic and be able to take advantage of virtualization and cloud, the various cloud advantages of cloud infrastructure. And again, on-demand analysis and decision support. How do you push a button and get some sort of decision support in the provider's office? Got to have systems that can do this, because this is not typically the type of common software that's out there is not typically geared toward this type of decision support. So in a way, you're looking at making, ideally, sort of a utility computing of healthcare model where you have an on-demand distributed system with analysis, data management, security, and ability to integrate different data sources. Is this possible? Well, yes and no, and you know, the future's already here, but it's not evenly distributed, right? As Gibson is quoted as saying. So we're seeing it in certain places, and you know, my hope is that we can keep moving it all forward, and you know, I think based on the fact that there's a lot of push from different areas, we're starting to see traction. All right, to drill down a little bit on these various components. Scalable data management. This has got to have a sharing infrastructure, ideally, and of course the storage side of it has to support the size of storage that you need. So this has got to scale pretty big, petabytes of data, and it has to handle all types of data. Those are all requirements of operating at scale. Cybersecurity and privacy, we've mentioned. Cybersecurity technologies include everything from firewalls, crypto, authentication, anti-malware, everything you can use to detect, prevent, remediate, everything else, various exploits and breaches. We have determined, or our thinking is that we focus on the endpoint, meaning where the data can possibly leave the system. In our systems, that's what we focused on and found that to be an important, more or less kind of an architectural decision, because there are other ways to handle this. You can look at what's happening on the network, or you can try to identify where things are in your organization. All those are important too. We're very focused on the endpoint. But in terms of the cloud elasticity, if you take a look at the slide, you can see this workflow staging, and at the beginning, the workflow doesn't require much processing horsepower or bandwidth or anything, so there's a tiny slice. And then it gets bigger as it needs to scale up, and then when it needs to scale back down again, it scales back down. And we're doing quite a bit here. Our networking group is doing quite a bit here with these types of frameworks, and we have a project called Exogeny, which is here at UNC and also at Duke, In other places, it's essentially an infrastructure as a service test bed that implements this elasticity component. And finally, decision support again. The visualization, the concept that visualization makes data more understandable. You see from the little graph there, you look at a bunch of numbers and then you see it on the graph. You can understand it. So let's apply this to the clinical workflow. How do we get to the point where we can support that in the clinic? So let's try putting all this together and give our dream car infrastructure. This is a vision for a back end. There's a management infrastructure. There's a cloud. This is analytics in it that is the part of the puzzle that handles the scaling up and down of all the analysis. Over toward the right in the middle is shared data infrastructure. So this whole thing is the kind of the punchline to this talk, right? The little star fort looking pieces that surround various institutions indicate that they have security and leakage protection on those endpoints, so we can feel pretty confident for some suitable definition of confidence, depending on how you want to do the system and set the policies and so forth, the data is not getting out. And in the middle, the circle, the blue circle, it says shared data. You have a data management infrastructure in there that's integrated in with the endpoint protection and security there. So again, this is a prototype vision. We actually have a system here that does this, but it's a very early prototype phase. It's called Secure Research Space, and it integrates these different elements. The point is to try to provide a comprehensive solution here. So you have the dynamic factor, scale up and down, things can be added or taken away as needed, and you still have like this secure virtual desktop endpoint, or however the endpoint's set up to interface with a system, a human or some other system. So this is obviously not what it's going to look like in a hospital exactly when you take a big provider of hospital systems and big equipment providers and the resource management providers and hospitals. And this is geared toward a vision in which there's an integration of researcher and the clinic to some degree. But the same principle will hold true. The architecture will look different in its realization, but the same basic picture would be true of a back end that does what we're asking for in terms of our dream goal for these types of systems. Here's what the front end looks like. So this is from the VDL project I've mentioned a few times before here in the talk, and if you look at the screen capture of it, you can see that there's information available to the practitioner, and it's put in as readable a format. It's very hard to get this stuff to present visually to people and make it understandable. And certainly this is not my area. I'm definitely more in the informatics and cybersecurity piece in the back end. So I can really appreciate seeing a thing like this, which is basically too hard for me to figure out how to do. In any event, if you look, this interface is answering a number of questions. Who's my patient? What are the health outcomes of that patient? What are recommendations based on a similar cohort? Again, evidence-based medicine coming into play. And then you can map patient data to a treatment guideline, and all this stuff is sort of something for the practitioner to look at and use as a guidepost or some sort of tool to get better health care for the patient. Disclaimer, the general trends here in the medium term are probably pretty clear, and I certainly believe those are going to happen. What this looks like in terms of a complete picture, like I've alluded to, the prototypes that we're seeing now will not necessarily be probably will not be what the future systems look like in various respects. I can certainly remember many years ago doing, was part of a research lab, we were doing geolocation services before most people were doing them, and we essentially had to take these small proto-tablet type PCs and strap GPS units to them. Then GPS units came from amateur radio supply type places. They were not integrated into a phone. There were no iPhones, none of that stuff. So a lot of this prototype stuff, even though it's kind of cool, you know at the end of the day it won't necessarily look like that, but the basic functions are going to be there. And the good news here, I think, is that even though the production solutions will vary, mutatis mutandis, I guess you would say, and in different research verticals, research versus teaching hospitals versus the commercial sector, government, healthcare, whatever, providers, whatever, all these different things will look a little different. But I think the good news here is that the trends look good, and as they used to say in the show, The $6 Million Man, we have the technology. We can make him better, faster, stronger, or whatever they said exactly. But the good news is that we have these tools in the tool chest, and things are going in the right direction. It's a very interesting time to be in healthcare and in this space. And so with that, I think that's pretty much it for the content. But would like to invite everybody to contact me if you have any comments, criticisms. Don't send any criticisms, but seriously, comments. We're very open here. It's part of the academy, so that's part of our mission to do what we can to help and increase the general knowledge base. And we also like to hear input. If there's anything that should have been in this talk and wasn't, I would like to hear it, and just whatever's going on out there. List of acknowledgements. So that's it for me with content.
Excellent, Michael. Really great presentation here. We do have several questions that have come in from the audience. So if you're ready, you want to do some Q&A?
Sure. Be glad to.
Let's do it. All righty. We'll take a question here from Kenny. Kenny asks, as big data grows, do you see geospatial tools, mapping tools, providing better insight and use for the improvement of healthcare?
I think that it would be hard to answer no to that. And in fact, there is some geospatial work being done here. I'm not really involved directly in it, but I think you will be able to see. I think those things will play together nicely. Is kind of the short answer. I do know there's some people are working on. There's a lot of public health work in this area, I guess, and people working on different areas and geographic areas and populations and this and that, and using it all for public health dashboards and systems like that. So I think we can only expect to see that increase.
Thank you. Another question here. This one's from Earl. He says, sounds like you built your own private cloud. Is it based on something like OpenStack or your own homegrown solution?
It's based on OpenStack. So it's actually pretty neat because they're using OpenStack. This is a group internal to Renci who has been doing an NSF project work in this area in terms of software-defined networking and elastically allocating compute and bandwidth. And they're using OpenStack as part of the solution. They've actually developed some racks of their integrated rack that you'd put at a point of presence, and it actually goes all the way down to the fiber. So you can get a slice with this system. The slice will have whatever compute is required and whatever bandwidth is required, but we're actually talking fiber VLANs essentially, and the network routing infrastructure operates in such a way that those can be allocated across different providers and so forth. So it's pretty powerful stuff.
Great, thank you. Laura would like to know if you could comment on cloud services like ClearData.net that built HIPAA in the cloud. Will this enable smaller players without large infrastructure to get into the field?
Yeah, that is an interesting question. I'm not aware of ClearData. I'd actually heard some discussion of whether Amazon was going to throw its hat in the ring on essentially indemnifying users in terms of HIPAA regulations. I don't know if that's happening or not. I do think that you'll see providers, hosting providers, managed hosting providers, and people in that space come out and say, we will give you some sort of, we'll give you some sort of guarantees, some sort of SLAs and business guarantees that we can handle your data and offload the risk of HIPAA compliance onto them, at least in terms of the data storage part, not the part of your business. So yeah, I can totally see. I really expect that to happen. Yes.
Great, thank you. A couple more questions here as we wind down the hour. And folks, we are at Q&A, so if you do have a question for Michael and what he's been talking to you about, please open your group chat widget, type it in, send it in, and we'll take as many as we have time for. Okay, Earl would like to know, are there any public resources or open databases available for health data science research and developers to experiment with?
Are there any open ones? Not that I'm aware of, but that doesn't mean that there are not any. There's a lot of, or at least not for people to use as development or sandbox or anything. There's a lot of data up that is related to publicly sequenced genomes, and there are reference data sets like that in different places. But I don't know of one, really an environment where you could work with it. I'm sure there are some. I just don't know what they are, I think is the real answer here. I'm sure somebody has put some things up to allow some kind of work in that area. Got to be.
Okay, thank you. Another question here. This one is from Shaji. What do you use for data visualization tools? Is it homegrown using open source, or do you use a commercial product? Also, if you could comment a little bit on the SDN part of the Elastic Cloud.
Okay, on the on the Viz tools, it's what I think is mostly going into the projects is mostly homegrown. Again, that's not really my area, so I don't know for sure. We do have a number of people here who are heavy into Viz and graphics, and they have indeed done a lot of it themselves. There may be tools out there that are useful. And SDN, on SDN, I guess the purpose of it in our context is to enable an infrastructure to control routers and switches. So if the routers and switches are set up such that they're able to be spoken to in these protocols and configured, they can basically be reconfigured on the fly, and you have a certain physical architecture that's always going to be there, but you can change, like the VLANing, you can just change arbitrarily, which is hugely powerful. You can allocate bandwidth to circuits, at least in terms of the fiber parts of this. You can do pretty much anything. Now, the caveat at this point is that I don't think these systems, there are commercial systems that you can buy for large deployments that probably have fair amount of this. It's hard to find support at every provider level for this if you're trying to reach all the way down into the routing, or even underneath the routing down into the firewall world. So it's still in its infancy in some ways, but it's very powerful.
Great, thank you. And we'll take our final question here from Joe. Are there any known prospects for EMR datasets? Trek had a medical track in 2011 and 2012, which were extremely valuable during the competition evaluation, but those EMRs are no longer available.
Yeah, I don't know. This is similar to what I said to one of the earlier questions. I don't really know of a replacement for those, and I hope that we get some. I wish I had a better answer to this question. I do think that those, like in the genomics world, there are lots of good reference sets up for different types of things, but the EMR data, I don't know of another one right now.
All right, and with that, folks, we are going to say a very big thank you to you, Michael, for sharing all your knowledge and expertise with us today and for presenting an outstanding webcast for us all.
Great, thanks for having me, and I appreciate everybody's attention and questions. It's an interesting time to be in this field, so.
And folks that attended today's event, we thank you for attending our webcast, and we hope you've enjoyed it and you've benefited from it. And for those of you that did send in your questions, thank you so much for those, because having your questions really adds so much more to our event, so we appreciate it. And folks, this will conclude today's webcast. Goodbye, everybody.